to discuss the current state of what we know about the different subtypes in pancreatic neuroendocrine tumors and the mutation profile. And then I will talk something that we're very interested in about this neuroendocrine, the plasticity in pancreatic neuroendocrine tumors, what drives it, and how it plays a role, especially in the more aggressive neuroendocrine tumors. And then in the second half, I will talk about the organoids and the work we do here to develop xenografts in what we call the Iacovos system. Okay, let's see if I can get this going. Okay, so where are we when it comes to neuroendocrine tumors, the different molecular subtypes? And I would like to discuss three of studies, which I think they approach the question using different omics approaches. The first one, it was by Angurash Sadanandam, was published in 2015. And what they use there is they use this microRNA and gene expression. And if we look at it, really, they talk about three subtypes: the IT subtype, which is usually dysfunctional, low metastatic potential, low Ki67, G1, G2. Then on the other side of the spectrum is what they refer to as the metastasis, like primary tumors. These tumors, they resemble more, they're very close to Punnet's metastases. They have high metastatic potential, are non-functional, very high aggressive. And in the middle, you have this intermediate subtype. Then there was a study by the group of Ilaris Marinori, who is here. Hope I will present this correct. So in here, they use the methylome. And again, this was a very nice study showing that now using understanding with the methylome that the first mutation with MENO1 mutation, you get these alpha-like tumors. And then in the second stage, you have these DAX and ATRX mutations, which leads to this intermediate subtype. Now, they also saw some intermediate subtype that they call wild type, and the assumption here is that this one maybe comes from beta cell lineage. Now, there was also a third study. This one was from Canada. And here, they look at gene expression and protein profile. And again, if you see here, they did identify two subtypes, what they call it PDX1 high and alpha-like. So these ones, they resemble more either the beta cells or the alpha cells, if you want to say so. And then they have this mesenchymal subtype, which is really characterized by what we call epithelial to mesenchymal transition. And then at the end, they have this proliferative subgroup, which is your very high-grade G3 Punnets. One of the caveats probably here in this paper is also they include some of the next. But okay, so what's I think the recurrent theme in so far, and hopefully something that we can all agree, is that when we move from a tumor that is functional, this can be IT or a beta-like or alpha-like tumor, or the PDX1 high or the alpha cell-like. When we move from this and that is functional to the more aggressive ones, to the more dedifferentiated ones, we always move to a more aggressive tumors with a poor prognosis. So in 2021, we published a paper, again, going back to the IT and MLP, using similar signatures as Angurash. We collaborated at that point with Ilaria, and we look at human patient data. And again, now you see patients with grade 2 and grade 3, they have higher MLP score. When you see at the different stages, now stage 3, again, there's very high MLP. And when you see here now, proportional survival, really, if you have a low MLP score, so if you're like IT, you really, we're doing very well. We know how to treat these patients. However, when you start having this high MLP score, you're doing poor. The same thing, I think it's the paper with Marinori. Again, you have beta-like or alpha-like, very good survival. When you move to the intermediate, poor survival, the same thing with this paper. Okay, so how different are these? Do we have really distinct subtypes? And this is something that I think now with new approaches we have moving to single cell data, we're going to start appreciating more this heterogeneity we have in neuroendocrine tumors. So this is a study, again, which they did a whole genome sequencing. And again, they identify what they call the ARX positive and the PDX positive, but you have now this double positive population, which is almost 25% of the tumors, and you have this double negative population. And you see that some of the cells, in fact, they express both the ARX and PDX. So we have to start thinking about this cell fate transition and how the cells now they can switch from one subtype to another, and what triggers this switch from one subtype to another. And again, in this paper, it's similar to the previous ones. If you have a PDX1, so that's like the selenoma or the IT, you do very well. However, when you have now the ARX positive or double negative, so these are going to look more like the alpha-like tumors described by Ilaria. Now you have a poor survival. For me, what's really striking, and I think that's kind of a low-hanging fruit and we have to really try to move this into the clinic, is this ALT. So hopefully soon we'll have a ways to do with immunochemistry and understand whether these tumors are really ALT positive and ALT negative. Really, this can really tell us a lot about the prognosis of the patient. So if you have a patient and you are reluctant whether you should do surgery or not, I think that can really tell us a lot whether we should go ahead and whether surgery will actually change the outcome in this patient. Okay, so now I'll move away from subtypes and let's talk a little bit about mutations. Again, the first study was done in 2017 by a group of Scarpa and Mayman collaborators. Most of the tumors there, it was G1, G2. I think they had 3 or 5 G3. They did whole genome sequencing. And what we learned there is that in the G1 and G2, again, primarily we have this MIN1, DAX, ATRX, a lot of changes in the mTOR pathway and chromatin modification. However, now there are more studies focusing
relatively normal adrenal gland with here in the middle.
Hey, Samira. Okay, so we have more studies now focusing in the G3 nets, which I would like to highlight here. So the first one, it was published in 2023, so last year. Very important here is that they selected 479 genes, so it wasn't a whole exome, but this one now it allows you to amplify the genes in the areas you're interested. And in addition to the commonly what they call ARTE mutations that we found in the Scarpa data, now what they saw is that these mutations in the CDK and 2A and P53. And I think now the field more and more appreciate that 30% of patients with G3, they have P53 mutations. Now, this was another study was published in 2018, and here again, they did whole exome sequencing. Now, this one was only from metastasis. And for me, again, what was really striking is this now copy number loss of CDK and 2A. And CDK and 2A, it's a protein that when it's lost, it leads to inhibition of both the P53 and the RB pathway. And I think previous studies, they really suspected that P53 and RB are involved in the progression of high-grade neuroendocrine tumors. For example, we know that MDM2 it's hypomethylated, and some of the others, CDK, they were shown before to be differentially expressed due to changes in the methylation. Now there is a new study published actually is in bioRxiv. Again, now they look at the clonal evolution in neuroendocrine tumors. This is done with matched primary and metastatic samples from 6 patients. They did whole genome sequencing. They also have a lot of data with RNA-seq. But the reason I want to highlight this is that, pancreatic neuroendocrine tumors It's really amazing. They are so heterogeneous. So if you see here now, the patient 2, it starts with the initial MEN1 mutation. But then if you see the 2 other subclones deriving from this initial mutation, they have a TRX mutation in the lysine 372, but the metastasis also has a TRX mutation, but it's a completely different mutation. And in patient 4, again, if you look at the first branch is MEN1 and DAX mutation, but then when you look at the 2 branches from there that seed metastasis, one of them has a PTEN mutation, and the other one has a mutation in this gene, the PTC5. So we do have a branch evolution, and it seems that in this case, they have a polyclonal seeding of metastasis. So really highlighting the really complex biology of neuroendocrine tumors, really complex. And this is a patient that it developed what now is called, I think, the hypermutation profile. It has a metachronous metastatic samples. And again, here it starts with a MEN1 mutation. All the primary have the ATRX mutation, but the branch that actually gives rise to all metastasis has a DAX mutation. Again, very, very diverse profile within the same patient. Okay, so if we try to summarize this, for me, it's really amazing. Pancreatic neuroendocrine tumors are very, very complex, rare, but so complex. But I think also highlights the amazing work that is done, especially the past 5 to 10 years in this field. So if we look at mutations, really there is not, even though probably this one is now the dominant MEN1 and then followed by DAX and ATRX, and then maybe probably P53, going from a functional tumor to a completely non-functional tumor. There are other many possible trajectories, for example, from MEN1 mutation and then having P53, or the CDKN2A, again, 30% of the patients, they just have a loss of CDKN2A. When it comes to cell of origin, again, we think now that alpha cell gives rise to the alpha-like cells. For me as a biologist, I cannot exclude the possibility that beta cells with maybe even MEN1 mutation will lead to this alpha-like phenotype, and I will talk about it more. So again, we do have 3 groups. The first one, the top one, the functional pancreatic neuroendocrine tumors. I think these are more or less, we know what's going on. With this, they maintain the cell identity. They have a very good prognosis. On the other side of the spectrum, I do like the term metastasis-like because they really resemble more than what you have in the metastatic setting. These are non-functional, and they have this progenitor identity, and there is a gray area in the middle. And really, it's going to be, I think, a challenge to find a good marker for this intermediate stage, and definitely we have to do a lot of more work. So my group and we're very interested in this progenitor-like cell identity of neuroendocrine tumors, and I'm going to talk about some of the work we're doing in this area. So we started this work when I was still a postdoc in the Hanahan lab, and really I did have an overlap with Anguras, who is not here. And it was kind of a debate we had when he left the lab. Really, these non-functional tumors that activate this progenitor, like now, is the cell of origin progenitor cells that are still sitting there in the islets, or are they actually functional tumors that they de-differentiate and they become non-functional? So we went back to the mouse model, and we collected really a big number of tumors. We did RNA-seq, we did proteome, we did microRNA-seq. And the first thing we did is that we refined the signature, what we call the metastasis-like signature, based both on protein markers and also RNA-seq. So having the signature, now we went back to the mouse and also some of the human data. I'm going to show here the mouse data. And we said, okay, now we have this MLP signature. What does it look like? right? When you compare to the developmental stages in the mouse pancreas. So if you look first at this secondary transition that happens between E13 and E18, now you can take the different stages, like E12.5 to 16.5, and you look at the MLP score. So you see now that E12.5, which is the earliest stage that we could have examined at that stage, back in 2017, that you have the highest MLP score. And if you go more and more to E18, when you have now specification of these progenitors, this MLP score drops. But this what really tells us is that these MLP tumors, they look more and more like these early progenitors in the pancreas. Then we use a different data set. In this data set, we had single-cell RNA-seq data. This is in the post-natal maturation. So, after birth, the pancreas is still mature. So we can still try to understand whether, in fact, these IT tumors resemble more and more mature beta cells or more the early stages. So this is the P0. So it is when you have a newborn mouse. And again, what you see when you use, again, immature beta cells, and you look at the MLP primary or metastasis, they really look like the immature. But when you look at the IT, they look more close to the mature cells. And we did the same with human samples, and we came into the same conclusion. So at least the conclusion back then, and it was, and the model here is that when you have the pancreatic development, you have this progenitor that will give rise to these mature islet cells. And when you have the initiation of these pancreatic neuroendocrine tumors, really what they do is that they trace back this pathway from progenitor to mature islet cells. So the very early cells, the IT, or we can call it alpha-like or beta-like, depending where they start from, they really look like the first cell. But then when they start moving back, we get all these different grades between, which is the intermediate cells, and then at the very end, you have these metastases like primary tumors. They look more like progenitors, and these are the very, very aggressive tumors. Now, what controls the transition between states? Obviously, there's a lot of mutations play a role, epigenetic regulation play a role, microRNAs play a role, transcription factors play a role. At that point for us, the best tool, it was an idea that was developed by Dr. Califano, which what he calls these master regulators. And the idea here is that you can have different mutations, and these different mutations at the end, they have to activate a specific signaling pathway that usually is controlled by a transcription factor in his model. And this transcription factor is going to be very important for the switch from one cell state to a different cell state. So we did that. First, we developed, you have to develop the model, so you need a lot of really data. You need at least RNA-seq from at least 100 samples, which we did have at that point for the mouse model. And we look, what are the master regulators? And the first thing you do, you look independently. You find all the genes that can play a role in the different cell state transitions. And then we ask the question, okay, what are the most important altered master regulators in the IT versus MLP? And again, we took the two different ends, right? The IT and the MLP, not so much in the intermediate state. And we came up with two transcription factors, the MACE2 and NHNGB3. And the way you can read this, the top are the genes that usually are positively regulated by this transcription factor, right? And the bottom genes here are the ones that are negatively regulated. So what you see here with red is that the positively regulated genes below MACE2 are downregulated when you switch from IT to MLP. And the ones that are upregulated and downregulated. So these one tell us that MACE2 transcription activity is shuts down when you have the switch from IT to MLP. And the opposite is from MLP, from HNGB3. So HLGB3, it's activated when you have the switch from IT to MLP. Now, we were very lucky because HLGB3 had a very good antibody. And we went back to the mouse model and also some human data. And again, this was a very nice collaboration with Ilaria and Aurel. But the mouse model, what allows us now is we can go at the very early stages. So we can understand what happens really early when you have this transition to IT to MLP. So if you see in the first column here, really you have an IT tumor. It's an early lesion. You see it's expressed high levels of insulin. It doesn't express the HNGB3 at all. Unfortunately, there was no MACE2 antibody. But here, the second one, it's on a very beautiful lesion where you can see here, again, in the middle, you have this high insulin positive. So this is your IT functional tumor, very low HNGB3, starts expressing HNGB3. And when now you see upregulation of HNGB3 in the periphery, you are losing the expression of insulin. So this is really very beautifully showing that at least one way to get this progenitor-like, metastasis-like primary tumors is from transition from a functional insulinoma. And at the end here, what you have is a fully blown metastasis-like primary tumors. You can even see that these metastasis-like primary tumors are way more aggressive compared to insulinoma, which is very nice, this round tumor, no invasion. If you look at the MLP, way more invasive. And in the mouse model, at least the one we're using, all metastases are MLP. There is no IT metastasis. Now we also look at some of the human data, again, with Larry and Aurel. And again, here, what you see here on the left side is a patient that it has very high insulin expression. And in the middle here now you have two patients with a heterogeneous population. In this one here now you have some that's with low insulin and start expressing HNGB3. And even on this sample here, again, you have HNGB3 high on the side, some of them with very high insulin, and some of them that co-express both HNGB3 and insulin. Again, showing that this transition, it does happen in the patients. The problem with patients is that most of the times when they come in the clinic, in my mind, they are already switched to non-functional, to the intermediate or the MLP state. And again, this is a patient with only MLP. And in liver metastasis in patients, 70%, they have high HNGB3. The other 30% is not. Again, definitely the biology of human patients is way more complex than the models we use. Okay, so then we went on, and this is, again, is published data. We look what controls the switch from IT to MLP. One of the things we suspect is maybe microRNAs play a role. We know that these two microRNAs, 181, CLD, they are expressed at very high levels in progenitors. We went on and we showed that they actually 181 downregulates MACE2. So again, this is a master regulator of functional beta cells and leads to upregulation of this progenitor, now master regulator. We also did single cell RNA-seq. This is from the mouse. Again, you see here the green, this cell cluster here is your IT, high expression of insulin, high expression of MACE2. The rest of the clusters here are start down-regulated insulin. So they haven't switched completely to MLP yet. So in this case, actually transitioning to full MLP, but the insulin is lost really, really early. And again, what you see, MACE2 is completely lost, and you start now having upregulation of HNGB3. So this is a new paper. It was published last year, 6 months ago. I think this is the first paper in which they went back and actually did single cell RNA-seq and NETChatter from human fetal pancreas. And this is a very, very nice paper. But again, what you see is the trajectories from the early progenitors, mid, late progenitors, early progenitors for alpha cells, mature alpha cells, and you see here the beta cells, they are splitting on the other side. And they did the same thing. They went and they looked, what are the master regulators? What really controls each cell identity? And then for the alpha cells, you wouldn't be surprised, right? The ARX is there. It's also expressed in the early progenitors of alpha cells. So really, ARX starts really early here. The MAF-A, it's one that they found in the beta cells. Again, fully mature beta cells. And MACE2, which again we found in the mouse model, it seems that it's very important in the identity of both fully mature beta cells and early progenitor beta cells. HGB3 on the other side, it's really this one, it's a progenitor master regulator, both in the mouse and in the human pancreas, and it's really highly expressed in the early progenitor in the pancreas. And as I have shown, it plays a role in the transition of, from functional to non-functional tumors. Now, well, of course, one way now we differentiate pancreatic neuroendocrine tumors and NETs is looking at proliferation. So we wanted to see whether there is any, what's the relation between dedifferentiation and proliferation. Again, here what you see on top is the same single-cell RNA-seq data from the mouse model. Again, cluster 1 is your IT, and then here you have 6 clusters of MLP. Shown here in red, this is the MLP signature score. All of them have very high MLP signature score, right? But when you look at the proliferation, it's not high in all of them. So the first 2 clusters here, now cluster 2 and 3, they have low proliferation. And then the last 3 clusters, they have high proliferation. And then the one in the middle, it seems like, again, is kind of this transition. It already switched to MLP, dedifferentiated, and now these cells, what they do now is that they start proliferating really fast, what we call hyperproliferation. And even in this mouse model that is driven by T antigen, if you look at the very early stages, the proliferation is very low. It's almost like a G1, G2 neuroendocrine tumor. It's really amazing. But then it really accelerates, obviously, at the late stages really fast. And you have both the IT and MLP start growing a bit faster. So the differentiation, it does happen before what we call hyperproliferation. Now I want to show you one more thing. So cluster 1 is, again, what we call this IT, and these are what they have, the functional tumor. So you see high insulin expression. But look now at cluster 2. So it's cluster 2, a big population here, derived from the beta cell-like cells. They express glucagon and MAF-B, which are alpha cell markers. And in fact, if you follow these mice very carefully and you measure the glucose levels twice a week, at some point after the MLP switch, what we see is that we see kind of diabetes. We can't even measure the glucose levels. They really spike really high up. And that lasts about a week. And then after that, the glucose levels, again, it drops. So we do, again, have this kind of, seems that we have a switch from insulinoma to an alpha-like, and then to this dedifferentiation. Now, we kind of, for me, really, I kind of trying to understand what's the association between IT-MLP and all the different other subtypes, because I think that we're all talking about the same thing, but coming from different omics approaches. So we went back to some of the published data from the human, from the Gorski data, and we look at their signatures. Again, this is the mouse data. This population has the IT, the high MLP. So again, when we look at their alpha cell-like or the PDX1, so these are their kind of functional, they are very high in the IT. But when you look at the EMT signature and the proliferative score, they are high in MLP, which kind of, it does agree with biology, that EMT will be higher in the MLP. And again, the proliferative score that they have in their paper, it really matches completely what we did in our paper. Now, EMT is very interesting. It's being implicated in cancer. So we want to understand what's now the relationship between plasticity, dedifferentiation, and the EMT. And again, this is something probably you can only do with mouse models. So we went back to the mouse model, and what we did here, again, we went very early at the stage when we know this dedifferentiation and switch happens. We stain for insulin, so this is your IT market. We stain for ECAT hearing. Now this is the market for EMT, loss of EMT of ECAT hearing. It designates switch from epithelial to mesenchymal-like. And we also stain for PEG10. So PEG10, we know it's a late MLP marker. So now what you see here, this lesion is losing the insulin. So these tumors here, they already switch from IT to MLP. But when you see the ECAT hearing is still there, it's intact. So this switch, this upregulation of this master regulator that it will license these cells now to switch from IT to MLP, it really happens before the EMT kicks in. And if we go to a different lesion, again, this also is very small. So these two events, they happen very, very closely. Now here what you have, it's a late MLP marker, right? So now you see the PEG10 staining, right? So if we focus on this lesion here, PEG10, late MLP, insulin in the middle, and now you see the ECAT hearing lost in your MLP samples. So in the early stages, activation of MLP, but no EMT, and then in the later stages, when you have this advanced marker of late MLP, now you have also EMT. So what does this tell us? So at least the model we have right now is that when you start, in this case, from an insulinoma, you activate this plasticity, dedifferentiation with different master regulators, and very closely, this one is very linked to EMT. Now, we don't know whether if you inhibit plasticity, if you also inhibit EMT. But also what we learned from the mouse model is that metastasis, it really happens very early before these cells start hyperproliferating. If we go back to this mouse model, when it still has low proliferation, if you dissect the liver, you already see cells are already seated in the liver. So very early metastasis, at least in this model. Okay, so if we are to conclude, what we learned so far is it's really very complex. And I think for me, it's really amazing biology. Neuroendocrine tumors, they switch from IT to MLP, different combinations of mutations. And again, they do retrace these embryonic stages. Okay, so I'm gonna switch really fast now, and because I don't have so much time for the second part, but this is something that we started now in my group. We don't have a lot of data, but now we went back to single-cell RNA-seq from human patient data. This is a study that was just published. We look again at the MLP. Again, we considered IT and MLP in human single RNA-seq data. What we decided to do is to go back to actually FFP samples. And with this single-cell RNA-seq for FFP samples using a new technology. You can see here we have 14 patients, 24 samples. We have both functional and non-functional primary tumors, metastases, both from liver and lymph nodes, and a lot of them have much samples. For example, this patient here will have primary, 2 lymph node metastases and 3 liver metastases. So these very early days, we have around 120,000 cells, which is, I think it's really amazing. And what we are doing now, we're going to try to understand what are the dynamics really of the different cell state transitions in pancreatic neuroendocrine tumors now in patients, and hopefully go back and again validate some of the master regulators and try to understand how they function. Okay, I'm going to switch to preclinical models, and I'm going to try to keep this very short, so maybe we can have some discussion at the end. So again, I think the past 5 years, it's been really amazing. We started with a paper in 2020 in which they did organoids only from G3. And if you read this paper, probably the conclusion is there is no way we're ever going to get organoids from G1 and G2. We had 2 amazing groups in Europe, again, from Aurel and Talia Dayton in Spain, recently showing that we can do organoids or patient-derived tumoroids from both G1, G2, and G3. So this is really, I think that it's very exciting time for the field. So when I came, this kind of was the status, and I really wanted to work with human patient samples. Kind of this what we identified as challenges, that we couldn't do a large scale of organoids from G1 and G2, but I'm happy to report that I'm wrong, because there are two presentations at the AACR the recent AACR, as I understand, from Dr. Pierre and Dr. Sapolsky, I think showing that now we can really do large-scale organoids from G1, G2, and we can do drug screening. The second challenge was really what we're trying to understand, can we do xenografts with low-grade nets? So we established a biobanking system at Sunnybrook. So now we get samples almost every week from the OR, and we do one of two things, or sometimes we can now do both, either derive organoids or derive these xenograft models in the Iacovos system. So I'm not going to talk a little bit about the organoids. I'm going to skip that. I think it's done by many people. If you want the protocol we are using, I'm happy to send it to you and share any of what we've learned so far. But I think both Dr. Satosky and they are ahead of us. So we've done this now from many and many samples coming from the clinic, and we can really see both engraftment, both from primary tumors and also from metastasis, as shown on top of these bright field images. And here, for example, you can see even the blood flow or in this tumor here and also here. Again, with ultrasound, we can quantify now what's the tumor size, and we can also look at the blood flow inside this tumor fragment. And this, again, we can quantify it with different techniques we use. I think what was very critical is whether these tumors actually will maintain the architecture. And I think what's really exciting for us is in this model that, every model has caveats and has pros and cons. But the question is, can we have the same structure we have in the patient? And here is one of these Iacovos on the outside. What you see here is the choroidal abdomen membrane. So this comes from the avian. And what you see in the middle there is this is the tumor fragment that we implanted from the patient. And what you see very nicely, you see these tumor nets. So these are your cancer cells, these are the neuroendocrine cells. What's really exciting is that the human stroma, it's also maintained in this model. And also, these are the avian blood cells. So the red blood cells in the avian model, they're nucleated, so we can really see them very nicely here. This another example is from the same patient, but this time is metastasis. And again, here it is now in the middle of the tumor engraftment, and you can see now these avian red blood cells. So what we think happens is have reanastomosis of the blood vessels that come from with the fragment, and you have again blood circulation. This time it's avian blood circulation. So we've done this now from different sites, and it seems that the take rate is very high. So I'm going to switch with finish with this one. Obviously, for us now, we have both platforms running, and these are some of the questions we're interested to understand when it comes to drug treatments. I think definitely the PDOs, organoids is the way to start. But what's very exciting for us now, try to do some validation using these xenograft models, which is using the patient samples. And of course, the question is there a different drug response in the organoids versus the Iacovos? Can we identify resistant mechanisms? And also, what's the tumor evolution when you do drug treatment? Do we have cell-fate transitions? Do we have master regulators and all this? So I'm going to stop with the most important slide, acknowledging my group, especially Dr. Kulatunga and postdoc in my group, and Zoe Wang are the ones who really did almost all of the work I presented. But I have been lucky to have very good collaborators. Dr. David Andrew is the one who has the facility with the organoids. Dr. Leon has the platform for the Iacovos. So I'm going to stop here. Thank also all the foundations, and I'm happy to take questions or discuss.
Oh my goodness, that was a fantastic talk. Thank you so much, Dr. Michael. I'd definitely like to open up the space for questions now. I know I have some of my own, but I'll save those. So if anyone has questions, please chime in.
I can, I don't want to take too much time. Excellent work, Iacovos. We obviously spoke already. A quick question to your single cell data. It's impressive. Obviously, your own PNET unpublished data. Are any of these having genetic backgrounds in your matched samples?
So we are doing the characterization as well because we have the sample, so we are going to do the profile, the genetic profile as well.
Yeah.
And yeah, so
yeah, I think that
we'll
that will be important.
Yes.
Because I think they'll have quite some different signature. And then I saw you have acinar and ductal cells in there. Are you using obviously also healthy islet cells as comparison?
No, we didn't, and because these are FFP samples from patients, so we didn't have access to normal samples. I don't know what would be the best source for this.
I guess would probably be with transplant units, or I guess in the US how it works. And again, I'm thankful to a collaborator of mine who has access to that, which is of diseased patient sharing their cells, and then obviously in the middle of the night you get a phone call and then she has someone of her lab accepting those cells. But it's excellent data. And then my last question before I let other people talk, your obviously ovoid model is amazing. How high throughput is that for drug screens?
So the last patient we did 50 from the same patient. So that's why I say for me, it's really, it's validating what you find in the organoids. So with 50, we think we can do a control and 2 drugs and their combination. And that's what we are doing now as a proof of principle. But that's really, for the most tumors you get, that's how much you can get. Now from the samples, we also, some of the samples go for snap freezing in the biobank. So if I ask for that, maybe I can go up to 100, but that's it. You can do 1,000 PDX-0 in a day if you have sample, but these are neuroendocrine tumors. So
excellent work. Thank you.
Thank you.
John, did you have a question before I move to the chat, or did that answer your question?
Yeah, I was going to ask about the genetic background as well, as that's going to be just really important. So definitely worth taking into consideration, as well as I think as it progresses forward, progresses forward, one of the great unanswered questions is in like say the NEM1 community where you're not really sure when to intervene and when to not, when there's multiple primaries. I mean, eventually having some understanding of that would be a really big improvement.
Yeah, that's a very tough question. And I think for me, really, that's when we need kind of more work with basic scientists, pathologists, and surgeons and clinicians. It's kind of, I remember one of my first, I attended a clinical patient discussion group, and with, and I sent a message to Dr. Singh. I said, hey, this tumor probably differentiated. And he replied to me, like, how is it going to change the prognosis? Should I care about it? And he's right? It's like, well, we do all this biology, but how are we going to translate that? Like, what does it mean? If you say HNGP3 high, should you say this is a high aggressive? No, it's not yet, right? I don't know. Probably Ilaria is closer to answer these questions with the work they did at the University of Bern. But I mean, ALT for me, I think that's hopefully it will go into the clinic. Hopefully we'll have a immunostaining at some point that we can use.
So that actually leads us into our question in the chat. Dr. Mikhail asks, can you please expand upon the clinical implications of your work, more specifically in a patient with multiple liver mets and only a few growing? Can we assume those growing lesions have dedifferentiated while not growing lesions are not dedifferentiated? So that's along the same lines.
Very limited samples right now. And I know, again, from when you look at the galliums imaging, and this is something I talk again with people with the radiation oncologists here, you see some of them, they have very bright, and some of them, they don't have any. So that will tell me, for me, that they lost SSTR2. And usually we see down regulation of SSTR2 with the switch from IT to MLP. So I think those probably are the ones that are not gonna, they are the more aggressive ones. But it's very early days. We would love to answer that question, especially when it comes to metastatic setting.
Yeah, absolutely. Ilaria?
Yeah, hi. Hi, everyone. Hi, Iacovos. Very nice talk. Yes, I mean, of course, it's alpha, it's beta, well, what it comes from. So a curiosity that I have is that if it does exist a RIP-DAC model in the alpha cells. So have you ever tried to have such a mice? I mean, do they exist? Because I think they do exist.
No, the RIP-TAG it doesn't, because the RIP-TAG, the way it was done, it was the rat insulin promoter, and unfortunately, yeah, so there is no fluxed RIP-TAG. For me, Ilaria, what would be very interesting now is to actually forget about the RIP-TAG and use MEN1 and maybe with P53 in the alpha versus beta lineage, and go back to that. Just use these two. Let's start with what we think is going to give the most aggressive phenotype, because kind of P53 now is in 30% of G3. And let's try to see what we understand from there. I mean, we do use the RIP-TAG to understand about the biology, but if you really wanted to understand, in my personal opinion, if we want to understand whether the first cell, it makes a difference in the progression, we have to go back to MEN1 and maybe P53, just to keep it simple. Start with 3 alleles, DAX maybe to make it 4, but who is paying for this? That's the issue now. When you ask money for basic research nowadays, you don't get it.
Yeah, but I mean, also in the MEN1, you have MEN1 knockout in the beta cells, they get insulinoma. MEN1 knockout in the alpha cells also get insulinoma.
I know. So what do you think about that?
So there is something that we're obviously missing, and I mean, it's not just alpha beta cells. We have other cells also in the islet. So
I agree.
so I think we have still a lot of work to do. And I can just add maybe a comment about the implementing of ALT fish in the clinical routine. I mean, in my experience, it's not like the most easiest, straightforward assay that you can do. And sometimes the evaluation, it's yes, it's positive, it's negative. So I would just go for DAX-ATX immunohistochemistry. That's it. It's easier, it's cheaper, and you get maybe you miss 5% of cases which will be positive but mutated, still retaining the expression of the protein. That's my experience, at least.
Yeah, I mean, it would be great, Ilaria. And I know you have a big TMA. We are also we are building a big TMA here as well, from 200 samples, 200 patients. If you ever want to validate what you are working in a bigger cohort, by all means, we are happy to help you. I mean, this is not kind of, again, I don't think that's kind of my area of expertise. And I think that hopefully the nice thing about this community about neuroendocrine tumors is understanding that this is a very rare disease, and the only way to move on is to collaborate and share expertise and reagents.
Yeah,
Thank
I
you.
agree. I'll put one note in. At UAB, we have several TMAs with representing Black and white patients with pancreatic neuroendocrine tumors. So maybe we need to have a discussion about integrating that as well. But Poe, I'll let you ask your question.
Oh, hi everyone. Iacovos, that was amazing. Thank you for sharing, and it's really exciting. I just have a technical question. Actually, it's really interesting. I didn't realize that there was up to like 30% of the NETG3 that you said would have like P53 mutation. So what do pathologists do you know, like will they classify it as a NEC then, or what are the criteria that would for them to say it's still a NET G3? Just curious.
I think I'm going to pass the question to the expert, Ilaria.
I don't know what, I don't want to say something very wrong here, but I don't think 53 would be enough.
Yeah.
It's for sure it's proliferation that also matters. So it depends how much is KK67 and the cell differentiation also, how the cell, the morphology of the cells.
Yeah.
But maybe the clinicians know better than me.
And my feeling is that if you look at G2 tumor for P53, if you see anything, it's going to be very little. It's going to be very, very small population. That's my feeling. And I think those probably then they have this advantage. And maybe and a lot of these G3, we have to go back and see. Maybe actually they were selected after all these therapies we do, right? So maybe the few cells that they have P53 or maybe was acquired during treatment, they really now they have this advantage and you see them as G3. I mean, a G3 we know is a bad. We don't need P53, really. I don't think so. But I think I agree with Ilaria. Can you do in the G2 ATRX and DAX and say, okay, this tumor is probably more aggressive. If you do a surgery, nothing's going to happen, or you have to use more aggressive treatment, or I don't know.
Well, thank you to both. I know it's really an interesting, and also it's not like, yeah, it's not a clear cut, and it's always, I think even pathologists are have to evaluate it like really carefully, and I was just wondering if, like, you know, maybe in the future like they will come up with a new guideline that will actually help a little, make it easier. Thank you.
Definitely. So thank you, Po. And I hate to end this conversation because it's been fantastic, but we are at time. So I want to say a big thank you to Dr. Michael for giving us an excellent presentation, and a thank you to everyone that tuned in today. We're really grateful for these conversations and the entire community. So Selena, do you want to say a few words before we wrap up?
Just to reiterate, thank you very much, Dr. Michael. Fascinating talk. And just to thank everyone for attending, and to let you know that next month we're actually a week earlier, so it will be on the 23rd of May, and we have Dr. Simon April Morn speaking.
Nice.
So we look forward to seing you all there. So thank you very much for coming, and we'll see you next month.
Yeah,
Thank you very much. Thank you. Thanks.
Thank you as
Bye-bye.
well, and
Thank you.
Bye-bye.
Happy to have you. Thank you.
Thank you.